prognostic improvement in their symptoms from atrial fibrillation, with around half having no symptoms of atrial fibrillation, compared to the control group, where around only a quarter had no symptoms from atrial fibrillation at follow-up. Some of this benefit might also be because by stopping drinking, they also lost weight. And we know that losing weight is also a very effective treatment for preventing atrial fibrillation. And certainly these are the things that we ask our patients when they come in, is to lose weight and to reduce their alcohol consumption. And simply by doing that, they can often get rid of their symptoms altogether. And we have to remember that ablation is not risk-free. This is a CT scan of a patient of mine from around 15 years ago, who had an ablation for atrial fibrillation using the NMARC device. And he presented a couple of weeks later with a fever and sweats and difficulty swallowing. And what you can see is air in his pericardial sac. And this is the cardinal sign of an atrioesophageal fistula. Unfortunately, despite surgery, he died. And we often quote our patients a risk of ablation of around a 1 in 20 risk of a major complication, 1 in 100 risk of a life-altering complication, and somewhere between a 1 in 700 and 1 in 1,000 risk of dying. But actually, the risk of dying may be much more than this. If you look on the right, you can see an insurance study from America, which looks at the percentage of patients who died early, within 3 months after having an AF ablation. And it's around about 1 in 200 to 1 in 100, much higher than we normally quote. Now, the risks of AF ablation are much higher in centres that have a small volume, but even so, we have to remind our patients that AF ablation is a treatment that can kill them and can be associated with severe side effects. There's a small risk, but a definite risk. So does AF improve prognosis? Well, there are 3 key trials that people often quote with regard to this. Cabana, which we heard about earlier, the EAST study, and the Castle AF study. So we'll start with Cabana. This was a study of ablation, the antiarrhythmic drugs, and it looked at the primary outcome, death, stroke, bleeding, or cardiac arrest. And it showed no overall prognostic benefit from ablation. Some people have looked at a sub-study and said if you did an analysis by the treatment patients received, there was a prognostic benefit. But of course, if you decide to do an ablation, you're choosing the patients who are better. And if you decide that someone who's been randomized to ablation shouldn't have an ablation, it usually means something else is going on. So we have to look at the randomized data. And the other thing the Cabana showed, which we're looking at here, is that actually as the patients got older, any potential benefit from ablation got less. And indeed, in the patients over 75, the trend was towards harm rather than benefit. So any potential benefits of ablation over medication seemed to diminish with age, but there was no overall prognostic benefit from ablation for atrial fibrillation. What about EAST? EAST was trumpeted as the great study that would show that early treatment of atrial fibrillation had a prognostic benefit. And the patients were randomized into 2 groups. The early rhythm control group, who were aggressively treated with antiarrhythmic drugs or with ablation, versus the standard care group. But it's really important when we're talking about the EAST study to remember that the early rhythm control group had to do 2 ECGs a week over a transtelephonic device. And if they didn't, they were phoned up to ask where their ECGs were. Whereas the standard care group had no ECG monitoring. So the EAST study was a trial of early rhythm control and regular ECG monitoring versus standard care. And even if we look at the EAST study, only 20% of the patients in the rhythm control group ever ended up getting an ablation. It did suggest a prognostic benefit of early rhythm control, but is the benefit because of the twice weekly ECG monitoring, or is it actually the benefit of the rhythm control? We know that compliance with medication is not particularly good, and we also know that the anticoagulation drugs do have a prognostic benefit in atrial fibrillation. So if the patients in the early rhythm control group had better compliance because they were having to do an ECG twice a week and being phoned up to check they had, then that might well explain some of the difference. And a sub-study of EAST came out last year looking at whether comorbidity had an effect on the benefit of early rhythm control. And what they did was they divided the patients according to their CHA2DS2-VASc score. So they took a subgroup of patients with a CHA2DS2-VASc score of greater than 4 and compared it with those with a CHA2DS2-VASc score of less than 4. To get into the Ihrs trial, you had to have a CHA2DS2-VASc score of 2 or more. The patients with the higher CHA2DS2-VASc score had less ablation, and it's important to note that at 2 years after entry into the trial, only 58% were on any kind of rhythm control. And what they found was if your CHA2DS2-VASc score was less than 4, there was absolutely no benefit of early rhythm control. If your CHA2DS2-VASc score was greater than 4, there was a significant benefit of rhythm control. And this group had less ablation and had more comorbidities, and it does suggest to me that the main benefit of the Ihrs trial might be in more aggressive treatment of all the factors around rhythm control, better monitoring and better compliance, rather than the actual rhythm control itself. And we can certainly not say that in the majority of our patients without comorbidity, there's any benefit of early rhythm control. And even if we exclude sex, so being female gives you a CHA2DS2-VASc score of 1, we found there was no benefit of rhythm control. So women with a CHA2DS2-VASc score less than 5 and men with a CHA2DS2-VASc score less than 4 didn't benefit from early rhythm control. Let's move on to CASTLE-AF. This was a fantastic study that took an incredibly long time to recruit. I started recruiting patients for this study in 2009, but it wasn't published until 2018. And it compared AF ablation with standard care. But it's really important to note that in the CASTLE-AF study, they really encouraged rhythm control in the standard care group. And it took patients who had symptomatic atrial fibrillation, an ejection fraction of less than 35%, and already had some form of defibrillator in place. The other odd thing about the CASTLE-AF study is how small a number of patients who entered it were. They screened 3,000 patients, but only 363 actually entered the trial. The majority of these had a non-ischemic cardiomyopathy, and importantly, more than half had already failed with amiodarone. Yet the patients who weren't randomized to ablation were still encouraged to have rhythm control treatment. So what was the outcome? Well, up front, the outcome looked good for ablation. It showed that there was a reduction in death with ablation, although the curves didn't divide until about 3 years. And there was also a reduction in hospital admission with ablation. But if we look closely at the CASTLE-AF study, then the walls do come down a little bit. The total number of events in the study was very, very small compared to what they should have expected. And if you look at this with a statistical eye, this would suggest that there may actually be, because the number of endpoints was so small. The trial wasn't blinded, and it was over 85% male, so we can't really apply this trial to women where we know the outcomes of AF ablation are often less good. It was stopped early, and rather unusually for a randomized trial, people were excluded after randomization. There was also a high dropout rate, and concerningly, this was twice as high in the ablation group as in the rhythm control group. And finally, there's a concern that they encourage rhythm control, which we know can have adverse side effects, even in patients who'd already failed with amiodarone. There's clearly a need for bigger trials and more detailed trials of this, and indeed currently in the United Kingdom, we're just starting to recruit for a large trial of AF ablation in patients with heart failure. It's also important to remember there are other options. In the APAS CRT trial, this looked at patients with a narrow QRS in whom the clinician had decided that there was no further option for rhythm control. They had to have had at least one admission for heart failure and had to have severe symptoms. They had a mean ejection fraction of around 41%, and they were randomized to either putting in a CRT and ablating the AV node or to aggressive rate control. And there was an improvement in the rate control in the ablation group of around about 10 beats per minute on average. And there was a clear benefit in terms of survival and also a clear reduction in hospitalization with a CRT and AV node. So in patients in whom you decide not to go down the rhythm control arm, who do have heart failure symptoms, then CRT and AV node remains a really good option with a good prognostic trial to support it. And the reduction in mortality was significant. So, coming back to my question, who should we ablate? Well, clearly those with symptoms particularly those with symptoms despite initial drug treatment. And who should we not ablate? Well, I think all the contraindications are relative. These are the ESC guidelines, and they need to look at risk factors for poor outcome. People with high blood pressure, diabetes, obesity, smoking, hyperlipidemia, alcohol, sleep apnea, and physical inactivity tend to do worse. Some of these are reversible, and certainly if patients lose weight, stop drinking and exercise more, not only do they do better from ablation, but we often find they don't need ablation at all. I screen all my persistent AF patients who I'm going to ablate for sleep apnea, and it's surprising how many of them do have sleep apnea and end up on treatment. We also have to be careful with patients who are older, particularly looking at the data from Cabana, and also patients who've had atrial fibrillation for a long time. And finally, we have to be extremely cautious about ablating asymptomatic atrial fibrillation. If they have heart failure, I do consider it, particularly if they have a normal left ventricular function and sinus rhythm. But it's important to understand that the trials of ablation in heart failure and AF, all the patients did have symptoms. I'll finish by looking at the guidelines. These are the 2020 ESC guidelines, and the two factors are really important. It's about symptomatic atrial fibrillation, and it's about considering patient choice. And it recommends you should always take into account the risks of the procedure and the patient's major risk factors for AF recurrence following the procedure. AF ablation shouldn't be some form of factory procedure where people come in with AF and we do as many ablations as possible. It has to be an individualized treatment option for the individual patient. And the key is choosing the right patients. If you choose the right patients, you'll get fantastic outcomes. These are our United Kingdom guidelines, and again, you have to have symptoms, and there has to be a clear correlation between the symptoms and the atrial fibrillation. We've all seen patients who come in feeling marvellous after a cardioversion, but when you look at the ECG, they've gone back into AF, and other patients who are very symptomatic, but when we look at their Holter monitor, there's no correlation between their AF and their symptoms. In the United Kingdom, we recommend the failure of some form of antiarrhythmic or rate-controlling drugs, but we do allow beta blockers and calcium channel blockers as a medication. You can't have an ablation if your BMI is over 40, and if it's over 35, you must lose 10% of your body weight. And we expect physicians to look at the patients and assess their frailty. If you have persistent atrial fibrillation, you have to have a relatively not too big left atrium. We're very cautious about ablating hypertrophic cardiomyopathy with persistent AF. And if you've had AF beyond 2 years, again, we would advise against doing an ablation if it's been continuous persistent atrial fibrillation. Similarly, if you've got significant valve disease, then probably you should sort out the valve disease before doing the AF ablation. And in the United Kingdom, we're now going to mandate from this year going forward that you have to do patient-reported outcome measures, PROMs, so that centres can show that they are improving the outcomes of the patients in whom they do AF ablation on. So I'll finish with my summary. AF ablation is a fantastic treatment for symptomatic atrial fibrillation, but drugs also do work really well. And there's no evidence of any prognostic benefit, except perhaps in some highly selected patients with heart failure, but even that's not certain yet. It's not risk-free, and in patients, particularly older patients who've got heart failure and permanent atrial fibrillation, then we've also got really good evidence for AV node and CRT implantation. I'll stop sharing my screen there. Thank you very much.
Thanks, Dr. DiPolo. It was a very nice talk. Of course, we definitely know the Indian perspective. So I will open the forum to questions for Dr. DiPolo.
I'll just start with the question in the chat box. Yes, higher CHA2DS2-VASc score means more comorbidity. So CHA2DS2-VASc is congestive heart failure, hypertension, age over 65 or over 75, previous stroke, vascular disease or ischemic heart disease, and being a female sex. All of those give you 1 point.
Yeah, so it's a nice balanced view. I'm Dr. Karthikesan, EP from South India. So a nice talk, as I appreciate your balanced view on AF ablation. So when you mentioned in your talk, you correlate their symptoms on monitoring. So what sort of symptoms you try to correlate? So how do you consider how long you monitor them to before deciding them for are they responding to medication or you consider them for ablation?
Yes, so some patients it's really easy. They get severe AF and they have to come into hospital. I have to say, I always get cross when people come into hospital and just cardioverted straight away. I'd much rather they were rate controlled and sent home for me to cardiovert. But if you have a patient with persistent AF, you cardiovert them and they feel better. And more importantly, they can tell you the day they went back into atrial fibrillation, then that is a good sign to me that they might benefit from ablation. In terms of paroxysmal AF, I think the symptoms can be quite variable. We often use Holter monitors, although increasingly we're using Apple Watches and Cardias, and we say to the patients, tell us your symptoms. Of course, one of the problems with that is if you have very sporty patients, they're so obsessed by their watch that as soon as it shows AF, they feel awful. Because their watch is telling them they're in atrial fibrillation. And you have to explain to them, perhaps, get rid of the watch and let us do a Holter, because we don't do an ablation just to make your watch look better. We do it to make you feel better.
Okay. So when you mentioned the early persistent atrial fibrillation, if their rate is controlled with the medication, you just leave them with the medication alone, or you don't aim for a rhythm control?
So with persistent AF, I usually offer them one cardioversion because you do find about 20% of patients who you cardiovert stay in sinus rhythm for a very long time, particularly where there's a precipitant. Or I've got a couple of patients who were heavy drinkers with a high body mass index, who've lost weight, stopped drinking, cardioverted them, and they've stayed in sinus for years and years. I think if one cardioversion doesn't work, and their rate is well controlled and they don't have many symptoms, then I wouldn't ablate them. But I think it's really important to try to get the right rate controlling medication. Certainly in this country, everyone thinks the only rate controlling medication is bisoprolol. And bisoprolol often makes people feel quite tired, lethargic, walking through treacle. We recently published a randomized trial showing that digoxin actually was better than bisoprolol for patients with persistent AF. And similarly, there's a trial from Norway showing calcium channel blockers often work better in terms of symptoms. So I do fiddle around, try a calcium channel blocker, try digoxin, make sure their rate control is good. If their rate control is good, they're not better on one rate controlling medication or the other. They're better after cardioversion and they feel awful when they go back into AF. If they've not got major risk factors for recurrence, I'll certainly offer them an ablation.
Age is consider the age of the patient. Do you have any criteria? So elderly people or less sedentary person or the active person at the younger age? Do you have any criteria?
Yeah, I think it's difficult. I think if they're very old and frail, it's very easy, and they often don't want an ablation. I don't have an absolute age limit, but I think once you get to 75 for persistent and 80 for PAF, I get more cautious. But if you're a very fit 79-year-old with PAF, I'd certainly do it if you're highly symptomatic. The group I find difficult are the young patients, the 40-year-olds, completely asymptomatic, good LV function, instantly found to atrial fibrillation. And there's a huge temptation to ablate them. But there's really no evidence for that. And I do quite a lot of medical legal work, and I've certainly seen a number of 35 and 40-year-olds who've died after an AF ablation, who never had any symptoms, had normal LV function. So I think we have to be really cautious with the younger patients. I don't think you can say doing an AF ablation in a 35-year-old stops them needing to have anticoagulation at 65, because we've not been doing ablation for 20 years. We've just been doing it for 20 years. We don't have long-term outcomes. So we have to ablate for symptoms. But I have to say, in a young patient who had heart failure with atrial fibrillation, even if they weren't very symptomatic, I'd certainly have a lower threshold for ablating them.
So the guideline says about, when you're refractory to drug therapy, you can consider symptomatic patient for AF ablation. So
and in young patients, they may choose that they don't want to be on medical therapy, particularly something like flecainide or amiodarone. I certainly wouldn't use in a young person. And to me, that's also an indication for ablation if they're highly symptomatic. But if, on the other hand, they're asymptomatic on a calcium channel or a blocker or a beta blocker, I probably wouldn't push an ablation.
When do you choose amiodarone as a drug of choice to control the rhythm control? I'm
using it actually a lot more after the Ihrs trial. Over 70, 75, I'm fairly happy to use it. Patients in their 60s who've got thyroid disease or who don't want to have an ablation, I'm using it. I'm very wary using it in patients under 60 to 65. because they do have a higher risk of thyroid disease, but I have 1 or 2 who've done very well, particularly after failed ablations.
Thank you. Dr. Dipendu, anything you can move on? You're muted.
Right, yeah. Sorry. So I think if there is no questions from the panel or the audience, I think we can go to the next talk to Dr. Ensom. So Dr. Ensom will talk about the AF ablation technologies, RF and beyond. So Bodhi, over to you.
Okay, are you seeing my screen?
Yes, I can see and hear you.
Great, thank you. Good morning. Thank you for asking me to present. I'm just going to give you a quick overview of the AF ablation technologies that exist. So turn off my alarm. No relevant disclosures. So before I talk to you about the different technologies, I think it's good to have a quick overview of where we are and how we got to this stage of AF ablation. The earliest AF ablation was reported as a case report by Hessegger and his group in 1994, but that was actually a right atrial ablation for atrial fibrillation in a patient who had previous multiple attempts at CTI. But going on from that was the landmark seminal paper in 1998, where the same team identified that the pulmonary veins in the left atrium were the triggers for atrial fibrillation, and focal segmental ablation here isolated the pulmonary veins and resulted in freedom from atrial fibrillation in the patient group. Moving on to 2000, in light of a number of our high incidence of pulmonary vein stenosis following focal segmental ablation within the PVIs, it led to a more wide antral circumferential ablation, the same strategy that we're kind of using now. So whilst this isn't an exhausted historical timeline, some of the key points I like to raise here are the introduction of cool tip catheters, contact force, ablation index, single shot RF ablation techniques such as cryoablation, and some of the newer techniques that are coming forward now, including pulse field ablation and combined pulse field and RF ablation. So I'll go on to talk a bit more about these now. So the aims and objective of my talk is to kind of explore the different approaches for pulmonary vein isolation. I'll try to focus on splitting this into the point-by-point PVI strategy against the single-shot PVI strategy. I won't touch much on the ablation strategies for persistent atrial fibrillation or hybrid AF ablation strategies, such as the convergent study, but these topics may be highlighted by my colleague, Dr. Kaller, but certainly they're worth reading for your further knowledge. So point-by-point strategy, what is this? So this is a standard workflow for the point-by-point strategy using CARTO as a 3D mapping system. You can see a multipolar catheter creating the left atrial geometry and assessing the pulmonary vein signals and anatomy. So if you can see, this is just a standard setup, standard workflow here. You can see, if I can point to you to the right side of the screen, you can see the PV signals once we enter the PV structures, identifying the signals before ablation. This map is an activation map, but we are able to assess the left atrial substrate, the number of the voltage and scar, and I'll show that in the next slide. But essentially, this is a standard workflow, trying to map the geometry, understand the anatomy, and determine the signal within the PVs beforehand, and assessing the substrate. So you can see on the left side, you've got a healthy left atrium with a voltage of greater than 0.05 being healthy, and anything less than 0.05 being scar, as you can see on the right side of the screen, with a patchy left atrium. So it's important to understand this as a strategy up front, but obviously you plan your procedure prior to going in, and if the patient has persistent atrial fibrillation, obviously you may want to consider more than just pulmonary vein isolation, but my colleague Dr. Kaller, as I mentioned, will discuss this later. So once we've created our geometry, the key parts before we isolate the pulmonary veins are firstly, as you can see here, contact force and stability. So on the back wall, we want to ensure we've got not too much force, but on the front wall, we want to make sure we've got a decent amount of force. So if you're on your thicker structures, such as the ridge on between the left pulmonary veins, you want to make sure you've got a decent amount of force. I would say generally more than 10 grams with at least 3 bars of stability using this system. Interlesion distance is very important, so we want to make sure that the lesions are not completely overlapping, but there is no significant gaps between each lesion, and I would say about 5 mil between each lesion is adequate. Ablation index, so ablation index is a force time integral. Different platforms have different indices and calculations. I would say that you have to have an idea of whether you're going to have a uniform index around the pulmonary veins, or whether you're going to choose to have a lower index on the back wall where you're more concerned about collateral damage and damage to the esophagus, for example, below the left pulmonary vein. My strategy of choice is to do 380 on the back wall and between 450 and 500 in the ridge and anteriorly. You also want to make an assessment of impedance drop to make sure that to kind of give you some feedback that the burn you're creating is actually going to be a decent burn. So you want to make sure that you're dropping the impedance as you're going along. And you can also have an identification of this from the impedance chart so that you can see if you're getting a decent impedance drop. If you're not, you may want to increase your force or increase your power. And finally, lesion time. So you want to try and get your impedance drop before at least 25 seconds burning. So if you burn for more than 30 seconds, that's definitely going to be associated with an increased risk of complications such as collateral damage to the esophagus, or even the pulmonary veins themselves, or phrenic nerve if you're ablating the right upper pulmonary vein. So finally, you'll have your map, and you'll deliver your lesion set. And as you can see here, wide antral ablation of the pulmonary veins as pairs, with some further work in the ridge on the right side. And at the end, you can make an assessment of your electrical isolation of the pulmonary veins, either by remapping and then showing that, as you can see here, you've got no voltage in the pulmonary veins, or even identifying dissociated pulmonary vein signals that aren't conducting back into the left atrium. One can also check for entrance block into the pulmonary veins, or even exit block from the pulmonary veins. So that's just a quick overview of the point-by-point 3D mapping workflow, but essentially the bit I wanted to raise with you is actually, despite doing the procedure now for almost 20 years with 15 years or so of 3D mapping, at best, the freedom from atrial fibrillation in the group of patients with paroxysmal atrial fibrillation is about 70%. So you can see that in this column here, freedom from antiarrhythmic drug therapy at 1 year at most is in 86% in one single observational study, but can vary between 60% up to 80%. So there's quite a variable efficacy, and that's probably because of different operator skill set, and that highlights that this is a very technically challenging approach to pulmonary vein isolation. Also, you see that the mean procedure time in this subset of studies that I've identified is still over 2 hours. So this is a long procedure with a definite a need for high quality skill. Coupling that, procedure complications still range between 0.05% to up to 4%. And these complication rates have been very stable for about 10 years. So none of the interventions that we've made over the last 10 years have actually reduced the incidence of or the complication rates for the most severe complications that we see. So those complications I've highlighted in red, and that's mainly driven by collateral damage, so conduction of heat through the left atrium to the surrounding structures. And you can see that whilst atrial fistula formation is about 1 in 200, it's a life-threatening complication with a high mortality, even if you are able to identify it. Generally, the reason the mortality is so high is that we definitely have a delay in identifying those patients who develop it, and it's often delayed to diagnosis and then surgical intervention. Pulmonary vein stenosis, once again, the incidence of or the complication rates have been static for the last 10 years. So what can we do? What has been done to try and reduce these complication rates? So one avenue over the last, I would say, 6 years is this idea of high power short duration lesions. So if you go back to the biophysics of atrial fibrillation, you'll know that there are 2 phases to lesion formation with RF. The first is the resistive heat, which is due to the direct contact between the tip and the tissue. And the second is the conductive heat transfer. And this is a time-dependent state, and this increases as you are burning and results in a deep transmural lesion. You can see from the schematic the amount of conductive heating is what is directly proportional to the esophageal damage. So with a long amount of conductive heating, so a long duration of burn, you're more likely to get a deep transmural lesion that will damage adjacent structures. As opposed to this, resistive heating due to a shorter burn but with higher power is more likely to cause a broader resistive burn and less likely to result in a long conductive deep lesion, and therefore will result in less damage to the esophagus. So what is the high power short duration strategy? But so generally anything above 50 watts for 5 to 15 seconds is considered as a high power short duration approach. So as I've mentioned, it results in a larger zone of resistant heating, a shallower, broader lesion, and therefore less collateral damage. So these lesions, are they durable? That's one thing we'll go on to talk about later on. So we know that even in the high power short duration lesion set, studies are now still showing that we can see esophageal damage. So in 37% of patients in the study that I've highlighted here, esophageal injury was still seen despite this being a high power short duration lesion. So what are the reasons behind ongoing esophageal injury despite this strategy? Well, in order to get a high power short duration, you have to have a high flow irrigation rate. So you have to be cooling the catheter at 30 mils per minute. So this reduces resistive heating actually and increases the lesion depth. So you still get that risk of collateral damage despite high power short duration lesions. There's very little time to get temperature feedback from the catheter tip to adjust the flow. So there's still the opportunity to have escalating treatment, escalating temperatures once you're doing this, and therefore that will result in a higher risk of, for example, steam pops, but also conduction of heat to the esophagus and surrounding structures. So one strategy or one catheter that tries to obviate this is the Q-dot microcatheter by a Biosense group. So instead of having the thermocouples at the tip of the catheter, they're at the tip and also at the side. So that gives you another way of getting temperature feedback from the catheter to adjust the flow rate. Indeed, there are 2 modes to catheter delivery or lesion development in this catheter. Very high power at 90 watts. So this is associated with a very short duration of lesion, so about 4 seconds. And then there is a Q mode where you may want to use different parts of the left atrium where there's a lower power of 50 watts. So you're more likely to get a deeper lesion and burn for about 5 to 15 seconds. So one strategy, for example, is to do Q mode plus, which is 90 watts at the back where you're worried about the esophagus, and then move to Q mode 50 watts in the ridge between the left pulmonary veins where there's thicker tissue and you actually want a deeper lesion. So depending on the temperature at the tip and the side of the catheter and the power, the irrigation rate varies for this catheter, and this therefore results in shallower lesions. So if you're able to understand the power at the tip and the temperature, the irrigation rates will vary, and therefore you'll get the outcome, which is the intended outcome, a shallower, broader lesions in areas where you're choosing high power, short duration. So looking at an assessment of this by Vivek Reddy and Tom DePotter's group, they identified that this resulted in a reduction in procedural times with no major complications reported. This is just a small study, and other studies to determine the actual optimal power and duration and flow rate are still need to continue. So as I've done, I've highlighted kind of the intricacies behind the point-by-point approach and the ongoing concerns about collateral damage. So I'm now going to talk a little bit about the single-shot approach. So these are the approaches that actually don't require point-by-point lesions or even 3D mapping of the left atrium. So obviously the most established single-shot strategy is cryoablation. So whilst cryoablation was originally tested in animals and in the early stages in 2006, it took a few years before the first generation Arctic balloon was available for commercial use and actually approved by the FDA. Further iterations of the catheter were made in 2012, and the large amount of data that we have is based on these second generation cryoballoons. So the second generation cryoballoon has a double lumen, which is cooled by expansion of nitric oxide. But in contrast to the first generation, there's an increased amount of gas flow. This meant that the balloon was more compliant with pulmonary vein anatomy. Also, there was a more uniform delivery of temperature across the balloon, so not just the distal or proximal part, but actually a global part of the balloon to ensure you got decent contact and decent antral ablation. A broader cooling zone also was the result of these iterations. So the FlexiCath Advance is a steerable sheath allowing for manipulation of the catheter into the pulmonary veins, and the spiral catheter that you can see that extends from the end allows for PV assessment and determining when the time to isolation of the vein has occurred. So obviously we have a lot of data with regards to cryoablation and its efficacy, and I'll mention that in a second. But the ongoing concern from this strategy is the risk of phrenic nerve injury. So transient phrenic nerve injury is thought to occur in up to 10, maybe even 11% of patients undergoing cryoablation. Persistent phrenic nerve injury, however, is still up to 2, maybe even 2.5% of patients. So it's still obviously the collateral damage is still a concern. In terms of efficacy of cryoablation, so a number of studies have looked at cryoablation as a first line for PAF with actually pretty decent results. You can see this STOP AF first study here, which is a randomized controlled study of cryoablation versus antiarrhythmic therapy as a first port of treatment. And you can see that ablation was associated with a reduction in the recurrence of atrial arrhythmia after the blanking period, which was statistically significant. You can also see that from my slide that the primary safety endpoint was also met with a reduction of or the same amount of complications in both groups. So there was no real, this is a safety endpoint, so there was no real difference between the risk of adverse events between patients with drug therapy and ablation. They actually felt that anything less than a complication rate of anything less than 12% was efficacious in a safety perspective. So another study of AF cryoablation as a first line was the early AF study. Again, a randomized control study that showed that AF ablation with cryo was significantly more efficacious than antiarrhythmic therapy in this cohort. The serious events, again, are comparable between the groups with no significant difference, similar to the first study, with 3.2 and 4% of patients in the ablation and antiarrhythmic arms having a complication, respectively. So, as I've shown, and we know from a number of studies, the effect of AF ablation in RF is about 70%. I've just reported, I'll go back. Again, it's similar in cryoablation as a first arm, 57% and 70% in the first study. So what are they like head to head? Well, one of the largest randomized controlled trials comparing cryoablation and RF ablation head to head in patients with paroxysmal atrial fibrillation was the Fire and Ice study. And you can see that there's similar amounts of patients in each group. I haven't shown the characteristics, but they're very similar ages and number of events and length of diagnosis in both groups. So with a mean follow-up duration of about 1.5 years, both strategies were comparable with no significant difference between them. In terms of the overall primary efficacy endpoint, you can see there was slightly significant, or there was a significance in the cryoablation group, but overall, the combined end group, there was no real difference. Again, there was no real difference in safety endpoints between the two groups, with 10% of patients in the cryoballoon and 12% of patients in the RF group having a complication. So one of the most important head-to-head studies, however, is the freeze cohort study. Why? Is because it was large. So we had over nearly 2.5 patients undergoing cryoablation and 1,800 undergoing RF ablation. And you can see that the primary end group, or the primary endpoint, again, was comparable, with 30% of patients in the cryo group versus 39% of patients in the RF group having a recurrence of atrial arrhythmia. You can see, however, from the forest plot that patients with undergoing cryoballoon had a significant reduction in all-cause hospitalization and a significant reduction in the need for repeat ablation compared to RF. And that's an interesting point. So moving on from cryo, and I'll give an overview slightly, is another form of single shot pulmonary vein isolation, the RF balloon. So the RF balloon, this is just one type of RF balloon, allow you to firstly map the left atrium, understand your PV anatomy, your substrate that I've already shown you in previous slides, and get that feedback when you're ablating your patient. So one criticism from cryo, for example, is that you can't understand the substrate. So if you're just doing PVI, if that's the strategy you've set up for, then that's all you're going to do pre-test, then that's fine. But if you're still uncertain whether this patient may actually be an early persistent or actually a PAF, understanding the substrate will help you determine what lesion set you're going to deliver. So actually, a point-by-point approach is something you would want to consider in those patients. However, moving on from this to this RF balloon, this RF balloon allows you to understand your lesion set. So it allows you to determine whether there's significant amounts of scar within the left atrium that may make you choose to undertake some linear lesions, for example, a box. So the RF balloon is a 28 millimeter multi-electrode RF balloon with a multipolar mapping catheter at the tip, which the balloon slides over. So it's similar to the lasso that you may have seen. The lasso creates the geometry and pulmonary vein anatomy and assessment of the pulmonary vein signals and substrate, and the ablation balloon slides over the top once you've created your map. So it's fully integrated with the CARTO 3 mapping system. Ablation with the HelioStar is done at about 15 watts with a flow rate of about 35 mils per minute. The duration of lesion on the back wall is about 20 seconds with 60 seconds on the anterior wall. So the overall outcomes have been studied in only one real big study by Vivek Reddy's group, the Radiance trial, which presented a 1-year outcome. So looking at the efficacy and safety of this strategy. So PV anatomy was not particularly challenging according to their trial, and that might be something that we discuss later on, but essentially they were able to achieve PV isolation in 100% of patients undergoing this study. Single application was able to isolate the PV in about 80% of patients.
If I might come in here, I think in the interest of the time and postgraduates, we might request Dr. Ensam to conclude here and kind of have some questions with Dr. Balbir Singh. If Balbir finds that good.
Of course. Your postgraduates probably will be aware of pulse field ablation, and perhaps we can discuss that in the comments. So I'm happy to wrap up. In summary, I wanted to show you that there are a number of different strategies for pulmonary vein isolation. Adaptations to existing strategies and novel approaches are focused on improving outcomes and safety, but these novel technologies require a long-term follow-up and further refinement, and then head-to-head comparison so that we can determine what is the optimal ablation strategy.
Sure. So just before Balbir comes in, sorry to interrupt you, Dr. Ensam, but just you answer some of the questions from Dr. Balbir Singh. If you can pull out from your laptop some electrograms of lasso, how the PV potentials look, and after ablation, how do you call it isolated, and similar things from a 3D, that would probably also interest the postgraduates. Balbir, over to you. Sorry to come in.
So
Ashish, can you hear me?
Yeah, sure. You are on. Yeah, please.
So as we saw a beautiful lecture on ablation of atrial fibrillation, let's go down to some points which are very important to understand. That ablation has risks, whether it is radiofrequency, whether it is cryo, whether it will be pulse field. There are some risks which we understand. But we also must understand that this is a very beautiful procedure. The more skilled we are, the better are the outcomes. So as a result, we should be prepared to do more and more ablations because it helps to understand. The second thing I want to add on is that I personally feel this point-by-point ablation going into the future will be a history. We don't want to spend so much time in the left atrium. We don't want to get more complications by putting one point and another point. So we have tried to evolve in the last decade in point by point, but the complication rate will still stay the same. So the future lies in one shot, single shot, get the pulmonary vein isolated and move on to the other one so that you spend the least amount of time. Third thing is for the postgraduates, that whatever ablation strategies have been mentioned in the past, PV isolation is the key to all success, whether it is persistent, whether it is paroxysmal. And fourth thing is that looking at those potentials, which I'm sure some graphs will come up, is very important. So what does the isolation of a pulmonary vein mean? So from the postgraduate point of view, a pulmonary vein isolation means that no electrical activity enters into the pulmonary vein and nothing comes out. So you have to demonstrate that you have done a robust pulmonary vein isolation, because in long term, this is the major determinant of outcomes. So we can have some slides if there are some potentials to be seen for these graduates.
Yeah, so Dibs, if you've got some images you can show, I'll respond to Dr. Singh's one of Dr. Singh's comments, and I totally agree that point by point is likely to die out in terms of strategy for pulmonary vein isolation, especially first comers. One danger, however, is that we become less skilled at mapping, less skilled at RF ablation, and therefore procedures such as persistent AF ablation, VT ablation may be more challenging. You'll be aware that the bulk of our work in the UK is AF ablation, and we do know that some centres offer PV ablation with single shots, for example, cryo is first up. But as a new consultant coming through, certainly the number of people with the ability to perform RF ablation is going to be reduced, and I think that's going to have an impact on the other ablations that we perform, such as VT or complex left atrial ablations for a left atrial flutter, for example. So I share your vision about a single shot for first timers, but I do have reservations that it will mean that some of us are de-skilled in RF ablation. Dr. Kalla has a question.
No, more of a comment. Thanks for the talk, Bodhi. I think the challenge which both you and Dr. Singh have said is that we want to make this effective procedure short and as safe as possible. And I don't think we found the perfect energy source yet. I think if we won't go back about 18 months, we were going to say that PFA was going to be the holy grail. And now if we look at the beyond 30 to 60 day data, we're seeing that the recurrence rates are similar. And it may be that we will exchange perhaps lack of collateral injury, which is important, for potentially reduced efficacy. And now that may be because of lesion maturation. Is it not deep enough to capture autonomic innervation? I think there's loads of biophysics that we still need to learn. And then certainly the RF technology platforms are trying to counteract this by reducing LA dwell time with things like QDOT, which you showed. So I think the optimum technology has yet to be discovered. And it's probably going to be a combination of single shot PVI, but with a catheter that can map so that we can understand substrate. And that's kind of where I'd leave that.
Yeah, I agree.
So for the interest of time, I've got some slides with the EGMs of PV sitters, but I will show that after Manish presents. So, in terms of the ablation technology, it depends on the center and the operator. That some centers does cryo for the first PVIs, and also after the advent of PFA, there are some centers which has moved on to PFA because it is a faster and supposedly the less complication. But the fact is that we don't have long-term data for PFA yet. But RF has been there for more than 20 years, so we know all about it. We know how to use it, but for cryos is there for like 10 years, and also many centers do cryo first. PFA is coming up, but I think we need more data to actually implement it to the patient level in large scale. So I think I will hand the mic over to Manish to present his talk on persistent AF, and then I can show some EGMs. Over to you, Manish.
Thanks. Can I confirm that the screen is presenting okay?
Yes.
Okay, great. So thank you very much to everyone in the Indian Heart Rhythm Society for allowing us from the Queen Elizabeth Hospital to participate in your education program. So I think I've got a difficult talk here as to what's new in persistent atrial fibrillation. These are my disclosures. So the question is, why is there a debate on this? So if we look at this study from 2015, and I suspect if we repeated it now, the PVI only arm would be slightly bigger. But overall, even in 2015, as AFib ablation had become a relatively mature approach, we can see that there was still a variety of techniques being used. So the vast majority were doing PVI only, but then we also see linear lesions, we see fractionation ablation, we see fractionation only, we see substrate ablation, a stepwise approach, and rotor mapping and dynamic mapping hadn't come in. So despite there being evidence from lots of trials
Sorry
showing
to
this.
interrupt. The slides are not
Yes.
moving.
Okay. Let me see what I can do about that.
If you can make it full screen, Manish, I think that will be helpful.
So do you see a slide which says scope of the problem?
Yeah, I
Yeah.
can see that. Yeah.
But you could
And
make
last,
presentation mode.
let me see if I can.
Yeah. Is it a way to make it full screen?
I'll try my best. Sometimes it's better if I just share the desktop. Is that any better?
Yeah. So, yeah, that's better.
Okay, sorry about that. So this is the scope of the problem, that persistent AF we know is associated with higher comorbidity. Patients tend to have a higher CHAS2 VAS score. We think that in Europe, there'll be 14 to 17 million patients with atrial fibrillation by 2030. And particularly in the UK, looking at a Western Caucasian population, half of our patients present with persistent atrial fibrillation. We know that rhythm control improves some outcomes in AF patients, but we know that it's mainly driven by symptoms and therefore hospitalization and healthcare utilization. And there are small cohorts of patients who have heart failure. But the question is, there is no consensus on what is the optimal ablation strategy in drug refractory persistent atrial fibrillation. And that's also borne out by that registry data or that survey data that I just showed you. But the next question is, surely we have our answer, that it's PVI, and STAR-AF2 answered it really well. So the three strategies that were tried in STAR-AF were pulmonary vein isolation with ablation of complex fractionated electrograms or CAFEs, or pulmonary vein isolation with additional lesions. And even if we look at the way this study was randomized, it was randomized as a 1-2-2 strategy. So perhaps the patient numbers were weighted into the more complex arm. But actually, we all see in this slide that pulmonary vein isolation was better than the more complex approaches. Overall, we're still looking at a success rate at a year and a half after ablation of about 60%. And a lot of trials haven't moved this on very far, maybe 5 or 10% here or there, depending upon the center mix. But the question is, or my question was always, is STAR-AF2 reflective of today's persistent AF patient? If we look at the data, the left atrium was not very big, 44 to 46 millimeters. 21% were in sinus rhythm on the day of ablation. In the CAFE group, there was no CAFE ablation done in 11% because they didn't find any. And in the linear ablation group, there was incomplete block in 25% of patients. So while the analysis was done as statistically correct, I'm not sure this reflected the true persistent atrial fibrillation population that we see today. And also, the more advanced lesion sets were not completed. So could this be a reasonable comparison? So then we look at PVI alone. So this is from one of my mentors, John Kalman in Melbourne. They looked at a systematic review and meta-analysis and showed that a single procedure, arrhythmia-free survival at 12 months for patients with persistent AF with PVI alone, 66%. So not bad. So as a default strategy, 2/3 of our patients will do well with PVI. But again, it's in the detail. So we've got nearly 1,000 patients, so a really big cohort in this study. The majority are young, 61 years old, no heart failure, again, small atrium. And this is important as well, that 2/3 were not overweight. And that's certainly something we're seeing in a changing population from a European perspective, that our patients are getting older, more overweight, and more comorbidity. But what about PVI plus? The most robust data for PVI plus actually comes from doing the Cox-Maze-4 lesion set. And I'll show that again later on when we talk about hybrid ablation, but it was a pretty big procedure. When it's done surgically, so obviously stenotomy, PVI, box isolation, appendage excision, a line to the appendage, mitral isthmus line, and there was also right-sided ablation with an intercable line. So this is the largest series from St. Louis, 500 patients, large LA. The median duration of atrial fibrillation was over 5 years. A whole bunch of them had already failed catheter ablation, but single center. And you can see that even up to 5 years out, patients are doing pretty well, and they're doing better than catheter ablation. But we have to look that it's a single center with very experienced surgeons. It's a huge procedure for atrial fibrillation, a huge procedure for a procedure that Dr. DeBona has already showed us does not have prognostic benefit for the majority. There is a 1% mortality acutely from the procedure, which is certainly much higher than endocardial ablation. They need an intensive care stay, and they have to stay in hospital for 8 days. So this cannot be the workhorse procedure for our patients. for a good number of years, the Bordeaux approach of stepwise ablation, which for our postgraduates, for example, is pulmonary vein isolation. So the patients are in AF, PVI was undertaken, and then fractionation ablation. So complex electrogram, high frequency, low amplitude, essentially marking areas of slow conduction were targeted to the point where AF organized into an atrial macro reentry rhythm or a micro reentry rhythm, but something organized, which could then be mapped and ablated. So that was the default strategy for some time. Long procedures, I remember doing them 4 to 5 hours, and this was then tested by this group in Germany, and it showed that once again, the PVI group did better compared to the fractionation group. So over the mid-2000s, it became the end of defragmentation, mainly because while the acute results may have been reasonable for the long procedure, atrial tachycardias and difficult to map and ablate atrial tachycardias was really, really difficult. So lines can work in some cases. So if we look at this data here, linear lesions may be better results compared to cafes. And this was a study done in Oxford, and I'm sure Dr. Bono had some patients in this trial. So they added fractionation to linear lesions and it had no benefit at all. So essentially a lesion set where there is a defined endpoint, i.e. PV isolation, entrance, exit block, and block across lines in experienced centers was likely to show some benefit. But again, these were quite small studies. But what about the cost effectiveness? This is an expensive procedure. So if we're just going to do PVI at our index procedure and PVI confirmation or re-isolation at our second procedure, we know that a number of patients will then go on to procedure number 3, because we know that from the meta-analysis that only 2/3 of patients get success from PVI alone. So if we have a look at this, we've got a 5% complication rate per procedure, so we want to limit those. If we do more complex lesion sets at the 3rd procedure, we're inevitably going to end up with a 4th. Then if we just look at a real back of the envelope approach of costing our ablation procedure in a socialized healthcare economy, we're looking at 2 procedures, about £11,000. And then at 65% success rate, we're looking at £16,000 per success. So it may be that PVI should be our default strategy, but could we refine that in a subset of patients? And I think this is where persistent AF is going. And one of the things is, are all persistent AF patients the same? So if we look at these 2 54-year-old patients, male, one has had PAF for 5 years, is relatively lean, continues to exercise, no cardiac disease, and a normal left atrium. But as the Alessi approach or the Alessi dogma of AF begets AF transitions to persistent atrial fibrillation. And if we compare it to this patient presented in persistent atrial fibrillation requiring cardioversion. It lasted 6 weeks. He's overweight, he's sedentary, he drinks quite a lot, and he's got a significantly dilated atrium. And then we had to undertake a cardioversion with amiodarone. So one has to ask ourselves, is the underlying substrate in these 2 patients the same? I think one would agree that this is more likely to be trigger-based atrial fibrillation with a transition in electrical substrate, and this may be something completely different. So these are the approaches that I think are emerging. So an empiric approach doesn't seem to work for our patients. A personalized approach needs to be explored. And risk factor assessment, which is very well described by Prash Thander's group in Adelaide, needs to be central to this. In terms of substrate-based approach, we can do bipolar voltage mapping. One question I've always had is, can MRI help us identify the patients in whom we are likely to succeed prior to ablation? And I'll show some data regarding this. Anatomical approaches are attractive because they're reproducible. So there's the Marshall plan from Bordeaux, targeting the posterior wall because embryonically it comes from the same area as the pulmonary veins. There is the hybrid ablation approach that Dr. Ensam mentioned, and there's dynamic mapping. So can we understand the electrophysiology of each persistent AF patient individually? So there's rotors, there's drivers, there's spatiotemporal dispersion, and I'll show some of that data. So voltage-guided ablation has been around for a little while. And what was interesting, so in this study from Pirakovsky, is that even if we looked in persistent atrial fibrillation, 65% of patients, so this is just observational data, had normal atria. So if we dialed the clock back 5 years, these patients may have ended up with stepwise ablation with a completely healthy atrium. And with substrate, we can see that unlikely to find it in paroxysmal atrial fibrillation. And again, in a third of patients, they would find scar, for example, low voltage on the posterior wall. And then other smaller studies, for example, like this one, compared voltage guided versus standard, and the results at 1 year were certainly better in the voltage guided, but these were non-randomized. So the most recent randomized trial, and it's taken a long time to get here, which is the Ihrs AF study, was published this year. And I'll just take you through it very, very quickly. So if we look at this diagram here, so we can see that this shaded area represents posterior wall low voltage, which in this group, the approach would have been pulmonary vein isolation, as we've all agreed, and then box isolation of the posterior wall. If we have a look at here, patients have had atrial fibrillation for nearly 3 years. The BMI is 30, so reflective of our current population, and a small number with long-standing persistent atrial fibrillation and the usual spread of comorbidity and just low normal ejection fraction. I'm not sure how useful millimeter dimensions for left atrium is, but again, probably within acceptable limits, particularly if we look at our most recent commissioning guidelines. So this is where I'd like you to concentrate. So they, in their supplementary data, showed what they would do for the variety of different substrate abnormalities that we see. So if there was low voltage around a pulmonary vein, they would encompass it. If there was anterior wall scar, they'd get what I call the seatbelt or an anterior line. If there was extensive scar on the front wall of the heart, they would then add a roof and then a line to the appendage and extend the right-sided pulmonary vein isolation into almost this sort of delta or triangle shape. The standard box approach for posterior and focal low voltage encompassed in the WACA. And overall, the success rate was better in the substrate group. So we're saying that if we can personalize the strategy for persistent atrial fibrillation, the results might be better. And again, this follow-up is only up to 1.5 years. It'd be interesting to see what this looks like at 3 years or 5 years. So I'm quite interested in MRI assessment despite its many limitations. So this is the classic image that Nasir Marouche produced for the DCAF-1 study, which showed that by segmenting or understanding the intensity of the MRI signal, you can get these beautiful 3D rendered pictures. Now, from Utah, you have to send them the image and they will do it for you. So we don't know how it's done. In Birmingham, we've worked with Professor Mark O'Neill and his colleagues at King's College London. So if we look at the MRI here of the left atrium, you'll see that actually finding late gadolinium enhancement is quite difficult. But as I'm just tracing it along here, you'll see that this white area is extensive posterior wall scar. And here you'll see scar anteriorly as well. So we've been able to replicate this in Birmingham. So you segment out the MRI and then use some special software, and then the red area delineates the scar. And this is one of our best examples. You can see here, this is a arrhythmia map of the left atrium, left-sided pulmonary veins, right-sided pulmonary veins, anterior low voltage here in the AP view. And you see it corresponds to the scar that we found on MRI, and huge zone of posterior low voltage, which corresponds to the scar on the MRI. Now, reproducibility is an issue, and that's something we're working on. And in the interest of time, I've not shown the DCAF-2 study, which was published last year, but that's essentially used the Utah approach, which is here, to allow MRI substrate identified personalization of ablation strategy, and it was no different to standard care. So maybe MRI is not quite mature enough outside of a research environment to try and allow us to select our patients or select our ablation strategy. So the next option is, if we can't do it by MRI, are there any targets beyond the pulmonary vein? So the vein of Marshall is the embryonic remnant of the left-sided SVC. I think this is the most interesting slide, in that there are discrete connections between the coronary sinus and the left atrial endocardium. And you can see here, these are the connections, and they may well be a neuroautonomic target, because if we look here, this is done by chat staining, so cholinergic staining, and we can see that there is cholinergic innervation of this area between the appendage and the left-sided pulmonary veins. And we know that vagal innervation has a role on atrial electrophysiology. So this has been explored by colleagues in Bordeaux, who undertake quite a complex procedure where they have ethanol infusion first into the vein of Marshall in patients with persistent atrial fibrillation, and that creates this area of low voltage. Then they remove all near-field signals from the coronary sinus. Then they have ridge ablation to complete the endocardial surface of the vein of Marshall, PVI, roof, and mitral isthmus line. So in a single procedure without antiarrhythmics at 12 months, they have a success rate of just below 80%. And again, this is not a personalized approach. This is the empiric approach in persistent atrial fibrillation. And with 2 procedures, the success rates are quite high. I think we have to see whether this is borne out in the longer term. And there has been a randomized trial by Valdebarano called the Venus trial, which showed not quite the same results, but the approach was different. But I think we need more longer term data for this, but it could be encouraging in that it's reproducible. One of the interesting things from looking at the Bordeaux experience is that it's much easier to ablate the vein of Marshall if you haven't done CS ablation already. So if you want to consider this approach after the index procedure, I'd say leave the coronary sinus alone and come back to it at your redo if this is an ablation approach you want to take. So for me, this was always going to be the easy approach. I thought the posterior wall has to be the answer. That's where we see the bulk of the substrate. Surely the box lesion set, which can be done safely in most patients, and we can confirm entrance and exit block, should be the answer. So the Kaplan study from Peter Kissler just has been published, which I've not included here, but the writing was on the cards for this approach, in that the POBI trial from South Korea randomized patients to posterior wall isolation, but quite a few had the anterior line or PVI, and the results were no different. So I've got to say, for my approach, this was slightly disappointing in that in patients like the ones I'm seeing with long-standing persistent atrial fibrillation, large left atria with substrate, the posterior wall did not add any additional benefit. But the one caveat I would say is that the posterior wall isolation was not on the basis of substrate assessment. So this is empiric. So all comers went and got posterior wall isolation done. So if we dial back a few slides, when I showed you Ihrs AF, where they only targeted the low voltage, that seems to be a better approach. So the hybrid approach, which Dr. Ensam mentioned, is an evolution from the maze procedure. And you can see that the lesion sets that were designed by the surgeons were quite extensive, effectively carving up both atria. And this has been replicated by surgical approach by this cryocatheter, which can be shaped with a stylet, which is introduced thoracoscopically by a subxiphoid incision. And it goes to the back of the left atrium and effectively sucks the atrium on to the catheter, and you apply these paddle-like lesions, and then endocardially 6 weeks or more later, you complete any of the gaps. And at the moment, this is reserved, or the patients we're using it for, and our program has just started, is with long-standing persistent atrial fibrillation, large atria. Some high BMI patients can be included as well, but there may be more complication. And this approach is giving better results. In the catheter ablation arm, you're looking at 33% success with a single procedure, which is significantly lower than one would like. And with a convergent, we're getting 50%. It's very difficult to compare these patient groups between the Ihrs AF population of substrate, hybrid approach. So I think, well, again, we need more numbers and we need more long-term data. But clearly, it is an advancement on the surgical maze that we can achieve the vast majority of these lesion sets now with an combined endocardial and hybrid approach. And we're happy to discuss that a little bit later on in the discussion session if needed. So finally, I'm going to talk about dynamic assessment of atrial fibrillation. Now, this has been done with a variety of technologies. It would be a whole different talk in itself, but we can see here that this is the Acutus technology. There should be a little video, but it's not playing. Oh, here we go. So Acutus is a ultrasound-based basket, which creates the geometry of the left atrium. And then it uses something called dipole mapping, which is quite complex physics, essentially mathematically looking at the wavefront propagation by a non-contact approach. And this is data from the Uncover AF study done in Oxford and in other centers. And they were able to see different types of patterns. You can see here in persistent AF that there's a line of conduction block here, then something breaks out over here. You can have rotation across areas of slower conduction. And here you've got what looks to be complex slowing activity across here. And this is what is targeted in the ablation. So pulmonary vein isolation, once again, is a cornerstone. And then different areas are then targeted and then anchored to conventional ablation lesion sets. And they found that the pathologic conduction patterns, which is this image here, was found predominantly on the anterior wall, and that's where we see a lot of scar, or the posterior wall. So one could argue that a box isolation and anterior line would allow us to get that, but we've already said that empiric approaches don't work well. So we want to do some personalization. And here, using AcuMap and de novo PVI, they were getting success at 1 year of 90%, which is certainly impressive. So if we look at all this data, I thought it's important to share what I do. So careful patient selection, which Dr. DeBono's talked about. Risk factor modification is really important. We're starting a randomized trial to aggressively target weight loss. I map in sinus rhythm, so if patients come in atrial fibrillation, I will cardiovert them. If no low voltage, I undertake PVI alone. If there is scar on the posterior wall, I'll undertake a box isolation procedure. And at the second procedure, if there's additional scar, I will undertake an anterior line or mitral isthmus line or target other low voltage. And certainly the ERASE trial has given me a little bit more confidence to do that. I have been trying Carto Finder, and I've tried it with 25 patients or so far. And I must say I've not either developed the experience for it or found it to be useful. And I think this is certainly something that I'm considering for patients with advanced substrate in multiple areas, is adding the vein of Marshall at the redo procedure. So in summary, emerging evidence that targeting low voltage zones can provide incremental benefit in persistent AF. I think risk factor management is absolutely critical. Emerging approaches are certainly anatomical for the vein of Marshall, but there's also the dynamic mapping approach. But as Dr. Singh said, PVI remains the cornerstone. And if we pick our patients appropriately, it may be that PVI is enough. Thank you very much.
Thank you, Manish. It's a nice talk, and as you know that persistent AF is a whole different, beast than the paroxysmal AF, and we have to deal with it in a different way. And there are lots of techniques, and most of them are RF based rather than the single shot, which we practice at our center. So I will invite questions from the audiences. To Manish, please.
Yeah, for the benefit of postgraduates, I would like to ask on Dr. Manish, in two persistent patients, substrate is not going to be the same, which you highlighted. In a long-standing persistent atrial fibrillation, how do you strategize your treatment? Who should go for rhythm control? Who should go for rate control? So based on the clinical available data, so how do you choose for the benefit of the graduates?
Yeah, it's a great question. I think one of the most interesting things you see in a lot of the trials is if we look at the mean age of patients in trials, it tends to be low to mid 60s. And certainly in the UK population, if we look at the mean age of our patient population, it's in the 70s. So real world versus trial data is really different, number one. I think we still don't have good categorization of what is the appropriate measurement of the left atrium prior to undertaking ablation. The trials are still going on the same 2D measurements in the parasternal long axis of less than 55 millimeters. But we've all seen that that may well correspond to volumes over 100, 150 mils. So I think that's also very challenging. So my approach is to use the volume or indexed volume. Once you're above an index volume of 40 mils per meter squared, I think you're going to get advanced substrate. Not in all, but in some. I think in the long-standing persistent atrial fibrillation ablation candidate, I would always try to cardiovert them first. If the volume's over 100 mils, I have a low threshold to use amiodarone for a short period of time, counsel the patient appropriately, and see if we can get them into sinus rhythm and there's improvement. I mean, for me, conceptually, it would be lovely to have a risk score, which may encompass duration of atrial fibrillation, CHADS2, VASC, maybe some fibrotic biomarkers, an MRI looking at fat levels or scar, tell us, should we even start? So that's the big research question that we're trying to answer, is whom should we actually start? And I think that's what you're alluding to as well. And I think that data is relatively weak. So my very simple approach in the clinic is look at the comorbidity, fitness of the patient, what is the size of the left atrium, and can I restore sinus rhythm with a cardioversion? If amiodarone fails, then I think rate control is likely to be longer term, unless, for example, there's LV impairment in a young patient, and then you counsel them that, are they willing to take an approach where there is a 50-50 chance of success? So I think this is a really difficult question that you've asked, and I think I tried to strategize by look at the patient, look at the left atrial substrate, and the best way for me right now is the volume, and then cardiovert and make a decision.
Great. In terms of available both point by point as well as single shot in a long-standing persistent atrial fibrillation, if you are going for a ablation, so how do you choose? Which one you choose? You just go for PV isolation and cardiovert them, or just go for substrate modification box lesions?
So my approach is certainly in a persistent atrial fibrillation patient is always to go point by point, because, as our fellows will say, I'm a real fan of mapping, to the point where some of my colleagues might make fun of me for the amount of mapping that I do. But I think understanding bipolar voltage, either in sinus rhythm or post PVI, I will cardiovert and reassess the substrate, allows me to individualize that strategy. I'm not very comfortable with just single shot PVI with a cryo balloon as a default strategy in a persistent AF patient, because I know that I'm only going to get 60% success at best. Now, the next question you might ask me as well, how do you know your success is better with your approach? And actually, when we did a retrospective review of all our patients undergoing AF ablation at the Queen Elizabeth Hospital, using a predominantly point-by-point approach, most of us assess substrate in one way or another. Our success at a year was 80%. And 60% of the patients in our cohort had a BMI of over 30 and had persistent AF. So our internal data would suggest that understanding the substrate has some benefit. But whether that is realized through randomized trials, I think we've only really seen it in arrays. So I think PVI for normal left atrium early persistent is probably very reasonable and you'll get good results. But large atria, more comorbidity, longer duration, I think cryoballoon or any single shot is unlikely to give you the success that you want.
Great. I think Dr. Debendu.
Thanks, Manish. It's a very nice talk. So next talk will be given by Atif. So Atif will show two cases, and I think in those cases we'll have the images of signals in the PV and how they get eliminated. So over to you, Atif. I think your talk will be the most appreciated by the fellows in India.
Thank you very much. Devs, can you see my screen?
Yes, I can see your screen, yeah.
Hi, my name is Atif. I'm working as a fellow in electrophysiology at the Queen Elizabeth Hospital. Thank you for the invitation. So in fact, I will discuss only one case, but we'll go through the various steps of decision making that can happen in a case like atrial fibrillation ablation. So it's a very interesting case and which highlights various steps and challenges as they come across while doing a procedure like this. So the patient is a 71 years old lady with history of recurrent persistent atrial fibrillation. She has a structurally normal heart with mild valvular heart disease. She underwent CT coronary angiogram, which showed no calcification. And she underwent her index procedure under sedation and local anesthesia in October 2022, in which the mapping of the left atrium showed normal left atrial voltage. So a strategy of pulmonary vein isolation was undertaken, and cavo-tricuspid isthmus ablation was also done at the end of the procedure. In fact, she tolerated the application of radiofrequency energy very poorly, and so there were concerns about the early recurrence of atrial fibrillation, and this is what happened. And she had early recurrence of atrial fibrillation and she was very symptomatic. So she underwent cardioversion after a couple of months after the first procedures. Although sinus rhythm was restored, but this was transient as she had recurrence of atrial fibrillation after 48 hours. Her medications included rivaroxaban, flecainide, and bisoprolol. So at this stage, a discussion with the patient was undertaken as to what further steps or management strategy should be adopted. So the options were to do nothing or to go for rate control strategy by optimizing the rate limiting medications like beta blockers or digoxin, but she was very symptomatic. The other viable options were trial of antiarrhythmic therapies like amiodarone or dronedarone. Redo ablation was another option, and then the strategy of pace and ablate was also discussed with her. So after discussion with her, she was listed for a redo AF ablation, which was undertaken under general anesthesia. And then we also did a transesophageal echocardiogram to rule out any thrombus in the left atrial appendage. A vascular access is always with ultrasound because it reduces the risk of complications. So 3 sheets were inserted in the right femoral vein. And then as you can see, a quadripolar catheter was advanced in the coronary sinus. Then we use a steerable sheet like Agilis and a contact force catheter like DF Smart Touch. It is placed on the His to mark the His, and then a transeptal puncture is taken with fluoroscopic and TOA guidance with the help of an SL1 and PRK needle. And once the wire is placed in the left upper or left lower pulmonary vein, then the sheets are advanced, and the second sheet is usually fished across the same transeptal puncture. So, in fact, once we were in the left atrium and we started mapping with a multipolar catheter, which was an octa-ray with Carto system this time, she went into atrial fibrillation. And interestingly, her pulmonary veins were found to be isolated from the previous procedure. For the benefit of the cardiology trainees, I would highlight that these are 4 surface ECG channels, and then there are the octa-ray channels which show no electrical activity, and on the CS channels, you can see there is irregular chaotic activity, which highlights atrial fibrillation. So she is in atrial fibrillation, but the left upper pulmonary vein is isolated, and so was the right upper pulmonary vein, the right lower pulmonary vein, and the left vein as well. So at this point, we completed the mapping of the left atrium, and a voltage map of the left atrium looked like this in PA and AP views. Now, red represents scarring and purple represents healthy voltage, and the other colors, they represent the intermediate zone. And as you can appreciate that there are widespread areas of low voltage which are present on the posterior wall, on the anterior wall, in the region of the mitral annulus, as well as in the region of the roof. So what should we do next? Because the veins are isolated. Now, to take a step back, we know that, and this has been shown by Dr. Kella as well, that usually pulmonary vein isolation is the cornerstone of ablation for paroxysmal and persistent atrial fibrillation. But if there is scarring on the posterior wall, or if there is low voltage myocardium, then a strategy to isolate those areas of scarring or low voltage can also be employed, as was tested in the recently published Ihrs EF trial, which showed that a substrate modification based on low voltage areas plus a PVI approach was superior to PVI only approach in freedom from documented atrial arrhythmias over a period of follow-up. So, taking guidance from this trial, we undertook a posterior wall isolation, or we ablated the roof line and the posterior line. And so this is the lesion set. So this is the roof line, and this is the posterior line. Of course, you have to be very careful on the posterior wall because there is a risk of atrioesophageal fistula and esophageal injury. But to debulk the posterior wall, we also did some more lesions on the center of the posterior wall. But even after all this, the posterior wall was not isolated. So we opted to cardiovert the patient with synchronized energy at this point. And so we undertook DC cardioversion, and as you can see, this artifact represents DC cardioversion, and immediately afterwards there is sinus rhythm, but immediately after a few seconds there is reinitiation of atrial fibrillation, as is evident on the coronary sinus channel. After a few minutes, a second cardioversion was attempted, but again there was reinitiation of atrial fibrillation. So now we were stuck that what to do, and but when we looked carefully at the reinitiation of atrial fibrillation, we could appreciate that the atrial fibrillation is initiated by somewhat regular activity in the CS channels, which has proximal to distal atrial activation, and then it degenerates into atrial fibrillation. So this is indicative of a mitral isthmus dependent flutter. So we decided to undertake mitral isthmus ablation at and adopt a lateral mitral isthmus line approach, a superior lateral approach, anteromedial, anterolateral, or total anterior approach. We usually employ a lateral mitral isthmus ablation approach, which means that we join the lower aspect of the left inferior pulmonary vein with ablation lesions to about 4 o'clock on the mitral valve isthmus. Now, they've also recommended an algorithm to follow, which essentially involves that first you have to complete the VACA or wide area circumferential ablation if that has not already been done. Then we undertake ablation of the lateral line, and then they do some more ablation on the endocardial side in the area of ligament of Marshall, and then if the mitral isthmus is still not blocked, then they go in the epicardium or in the CS, and they do some low power lesions to achieve mitral isthmus block. So it is important to note that in more than half of the cases, it is difficult to achieve mitral isthmus block by only endocardial ablation, and then you have to compulsorily go into the coronary sinus. If there is an option of vein of Marshall ablation, which has been touched by Dr. Kalla, that is also an alternative approach. So we undertook a lateral mitral isthmus ablation approach, and you can see the lesion set, which joined the lower or the anterior lip of the left inferior pulmonary vein with the mitral annulus. And so we were hoping that we would get block. So to check mitral isthmus block or bidirectional block across mitral isthmus, we have to pace from the left atrial appendage, as has been highlighted in the top left tracing of this diagram, that if you pace from the left atrial appendage, if the activation in the coronary sinus is from distal to proximal, it means that the mitral isthmus is not blocked. But if the activation changes to distal to proximal, it means that mitral isthmus block has been achieved. And similarly, you can check the bidirectional nature of block by pacing from different bipoles of the coronary sinus as well. So this is what we did. And in fact, we took the Octaray catheter into the left atrial appendage, and we paced, as you can see from pacing spikes in the LA appendage. But if you look at the CS channels, the earliest atrial activation is in CS12. Now, the CS12 has got a small far field component and a late sharp component. In fact, the small far field earlier component represents that this mitral isthmus is still conducting epicardially or in the CS, and the late sharp component represents that probably the line has been blocked endocardially. So this is sometimes called a chevron pattern. So we took the ablation catheter out from the left atrium and mapped the coronary sinus, and in the distal coronary sinus we could find a very fractionated signal, which was earlier than CS12, as you can see on the ablation distal channel. And with the help of a couple of ablation lesions here, utilizing 25 watts of power, we were able to achieve mitral isthmus block, as is demonstrated by proximal to distal ablation, distal activation in the CS. So this is a glass mode which shows that the epicardial lesions, or the lesions we did in the CS, they sit right next to the endocardial set of lesions in the mitral isthmus, and hence we were able to achieve block. Now, ablation in the coronary sinus has certain risks as well. It can lead to injury to left circumflex artery. The coronary sinus acts as a heat sink, and sometimes it's very difficult to achieve transmural lesions. So a cautious approach has to be utilized, and then you have to flex the catheter in the direction in which the ablation lesions are right adjacent to the endocardial lesion set. The patient has done well and has recovered well from the procedure and has been largely symptom-free. But if there is a recurrence of symptoms, then our other approaches or other options would be to use amiodarone or dronedarone. Now we know that amiodarone has a lot of risk factors like thyroid dysfunction, risk of interstitial lung disease, liver toxicity when used on a long-term basis. It can also lead to corneal microdeposits and photosensitivity. So the patient has to be warned against all those possible side effects, and dronedarone, of course, has to be given with liver function monitoring as well. The other option, if the patient is intolerant of these medications, is to implant a pacemaker and then to go for AV node ablation. But we usually reserve this option for patients who are of older age. So to conclude, we know that although pulmonary vein isolation is the cornerstone of AF ablation strategy, but a substrate-based modification approach in addition to PVI is helpful if we can find low voltage areas in patients with persistent AF who have got dilated left atrium. But of course, an individualized approach has to be undertaken. Mitral isthmus line ablation, posterior wall isolation, CT ablation are required sometimes in certain cases to optimize outcomes. But an empiric mitral isthmus ablation is not recommended at present because sometimes it's difficult to achieve block. And if the line is not blocked, then it's potentially pro-arrhythmogenic and can lead to precipitation of flutter circuits. And antiarrhythmic drug therapy and pace and ablate strategy or alternate options if there are recurrence of symptoms. So I thank you all for your attention. And if you have any questions, you're more than welcome. Thank you.
Thanks, Atif. So I'll first open to the forum for any questions.
Yeah, Dipendu, if I may come in, Ashish here again.
Hi.
Great presentation by Atif demonstrating different aspects of ablation in AF in persistent case. This is any Bode or
Yeah, I've got some images. So can I share my screen, please?
Yeah, sure. While you share, I'll just put up the question is, can you explain to the postgraduates the concept of blanking period and how do you treat during this time and thereafter? How do you use the antiarrhythmic drugs which are previously ineffective or effective? How do you manage the antiarrhythmic therapy after ablation? And probably one of you can also describe a bit as to what your anticoagulation strategy is after ablation. Yeah, Dipendu, you can tell, or Manish can answer in the meanwhile, or Atif can, anybody can.
Sure, I'm happy to discuss that. So the blanking period is a 12-week or 90-day period after AF ablation where any recurrences are not thought to be associated with long-term outcome. So let's say I had an AF ablation and at 4 weeks, I had an episode of atrial fibrillation. Now, as a patient, I might feel very upset about it, but actually one could tell the patient that it is very common to have recurrences within the first 12 weeks. It may be related to healing and inflammation and irritation of the myocardium. And the original studies put this value in to effectively not allow for early re-intervention. And the finding that any recurrence of arrhythmia early within that period did not have an impact upon long-term outcome. Now, my own experience is that as you get later on into that 12-week period, so the later the recurrence happens, the more likelihood is that you're going to be either trying rhythm control with drugs and cardioversion, or you're going to have to go do another ablation. So that's my own personal approach. So if it happens within the first 2 to 4 weeks, it's much more likely to be inflammatory. If it happens at week 10, I think it's much more likely to represent reconnection. In terms of my strategy for the patients, we tend to cardiovert them if they have symptoms in that acute phase because you want them to maintain sinus rhythm. And again, the antiarrhythmic strategy is planned anyway for these patients before. So large atria, complex substrate, which is another reason why I